Hello, and welcome to This Week in Sociological Perspective. I'm your host, Samuel Roundfield Lucas. This week, we discuss the removal of mask mandates from airplanes and other public transit. But first, I recently spoke with DeAngelis, doctoral student at the University of North Carolina and the Carolina Population Center, about his recent paper titled, Moving On Up? Neighborhood Status and Racism-Related Distress Among Black Americans. The paper is to be published in Social Forces and is sole-authored. Mr. DeAngelis, thank you for joining us.
Yeah, thanks for having me.
And so I want to begin, your paper, your analysis begins by noting that Black Americans have worse health than do white Americans. Mm-hmm. What hypotheses have scholars developed to try to explain this longstanding pattern? I mean, some of them anyway, that they've developed to try to make sense of it.
Right, yeah, so I think one of the more common hypotheses, maybe one of the more longstanding ones, is that, so in this study, it's about Black-white health disparities, that those are due more fundamentally to socioeconomic inequalities. So say the fact that maybe Black Americans own less wealth than white Americans, they have lower education levels on average, earn lower incomes, and then that restricts Black Americans from moving into quote unquote higher status neighborhoods. All these more fundamental socioeconomic inequalities are like underlying the health disparities, because in our economy, you kind of need money to buy health. That's sort of the premise of fundamental cause theory and medical sociology. So I think that's one of the more predominant theories. And then there's an alternative theory that says, well, even if we were to quote unquote, if we could even do this counterfactually, like hold socioeconomic status constant across groups, there's still going to be like a persistent Black-white health gap due more specifically to racism and persistent like interpersonal discrimination and stressors that really Black Americans can't escape no matter how high their status, their socioeconomic status is. So those were the two theories or explanations I was kind of grappling with in my paper.
So yes, yeah. Your paper brings in neighborhoods. Right. One of the things it brings in. And right. You know, as we know, neighborhoods are segregated by race and by earnings and wealth. Actually, I kind of know that as a fact of the society, but I don't know personally how, you know, what the levels are or what the what the trends are even. But it's kind of clear that there's some racial and earnings and wealth segregation. Mm-hmm. But as you say, what you're saying is that economic disparities may not explain this racial disparities in health. So when you consider a role for, does that make sense what I'm saying? I'm
yeah, right.
So if we set aside the part of economics, when considering a role for neighborhoods, are you trying to bring in racial residential segregation as the missing explanatory factor? I mean, correct me if I'm right. Misstating what's being done.
I see what you're getting. Yeah, so that has been one. So yeah, that was an explanation. But so the idea that residential segregation is also like underlying Black-white health disparities is kind of in a similar vein as the argument that individual socioeconomic status is driving Black-white health disparities. It's the way I read it. It's that same logic is sort of projected onto the neighborhood context and saying, well, if Black Americans could move into integrated higher, or maybe not necessarily racially integrated, but higher status neighborhoods, probably more racially integrated, just given the history of segregation and in our country, that would somehow improve their health. So that was kind of a meandering answer to that.
But is your paper then sort of taking a different tack, or is it taking the same? Yes. Is it in line with that line of claims?
Right. So my paper is trying to sort of challenge that claim. So by showing really that, yeah, even if Black Americans moved into quote unquote higher status neighborhoods, given the history of racial segregation in the United States, that's going to mean usually more white neighbors. And so when Black people move into these spaces, they're around more white neighbors, and that introduces a whole new set of problems that could sort of suppress the health benefits of moving into these better neighborhoods. And the set of problems that my paper identifies as interpersonal stressors and discrimination. And so basically my argument is I'm trying to counter or like put a brake on this idea that like moving, like allowing Black Americans or getting Black Americans to live in quote unquote better neighborhoods is going to improve their health. Really, what I'm trying to argue is actually, white people also need to change, and these more high status spaces also need to change.
Well, theoretically, before we get to the analysis, theoretically, what's the chain of reasoning or the pathways through which African Americans moving into higher status neighborhoods end up theoretically, what's the explanation for why that would actually not lead to health improvement?
So I think, in my paper, I look specifically at interpersonal discrimination. So there's been plenty of research that shows that when Black Americans move into higher status neighborhoods or move into, or, occupy like higher status occupations or attend prestigious universities, all these spaces historically have been white. And so, right, when a Black person moves in and begins to occupy spaces like this, they are being exposed potentially to more interpersonal discrimination. I think that was basically the theory that my paper was going for, is that by moving into these neighborhoods, their risk of exposure to discrimination is going to increase. And that from there, then I identify a bunch of kind of a grouping of like biopsychosocial stress processes linked to discrimination that in turn kind of harm the body. And those sort of countervailing processes like suppress the health benefits of, potentially moving out of more, the segregated Black neighborhoods that are traditionally, usually considered like more toxic because of, increased pollution or crime or whatnot.
Yeah, so you mentioned, so these things are these physiological responses are like at some point I remember, these concepts of this, what's goal-striving stress and hypervigilance, and are these grounded in are they grounded in physiological responses, or are they results of physiological response? How are you thinking about how, I know I'm referencing in these terms probably vast literatures that which I know nothing, but you know something. So how would we see those playing a role, or am I maybe they don't play a role?
So yeah, I guess the model that I'm testing is showing really that, oops. 1 second, sorry. Geez. Sorry about that. So yeah, the model that I'm testing, assumes that really like to be Black in a predominantly white space, to be exposed to discrimination, that sort of can train for anyone, right? Just being in a space where you feel you're treated sort of like the black sheep of the area, can sort of train your brain and nervous system to always sort of anticipate future like encounters of that nature. I think that's where the whole idea of vigilance and anticipatory stress comes from. So really like, that was like one of the main, like I said, one of the main focal points of my model was this idea of goal-striving stress, of like feeling like you are being somehow prevented from, reaching this status, this desired status, and then you have to kind of like push harder, and then you're facing these barriers. And I link that to actual like experiences of interpersonal discrimination linked to the neighborhood context.
So just as we turn to the data, you're using data from Nashville, Tennessee. what are some of the useful features of this data set that allow you to get at these kinds of questions?
And I think just like at that broad, like population level, if you look at black-white segregation patterns in Nashville, it reflects basically like the national average. It's not like, so I think Milwaukee might be like one of the most segregated. And then I think like somewhere in Utah, like Provo, Utah, or something is like the least segregated. And then Nashville's kind of just right in the middle. And there's historical reasons for that. If you look at like the history of like civil rights movement, a lot of the early sit-ins and even before then, like during Reconstruction and, a lot of the early historically Black colleges and universities and medical schools were started in Nashville. So there's kind of been like a push for desegregation in Nashville historically. Mm-hmm. So it's kind of an interesting historical space to look at this. And then, that those movements, the Black movements, have also been met with, from white Americans. Like there have been books written on sort of how Southern, whites have dealt with the civil rights movements in Nashville that are interesting, where that could seem to lend itself to like making Nashville a unique site to look at what happens when Black Americans sort of move into historically like isolated, affluent white areas. I just thought it would be kind of just interesting space for that.
Yes, well, it sounds, this is one of the tyrannies of national analyses. Is there's sense of, and I do research using national data. And of course, you get this average kind of statement, and maybe you get some sense of the variability. But each place has got these deep stories and histories, and you're kind of glossing all over that. And so this is it sounds like this is an interesting case study, just like the U.S. is the case study of nations. That would potentially illuminate, I mean, from what you're saying and what I'm gathering, is illuminate the dynamics and the process that might be operating. And then we can then look at other places to see, well, maybe it does. Also, it sounded like you had some really good biophysiological kind of data in this. I don't think you have it in every city. So it's nice that it's in a city that's got these other positive features too. So.
Right. Yeah. And so the sample, the data were collected by R.J. Turner, which is a big name in like stress process medical sociology. And he chose Nashville for these reasons. I mean, he was working at Vanderbilt at the time, but he also chose to oversample like high SES Black Americans to get like, so that he can sort of get like good like variability in socioeconomic status across Black and white respondents. That was another draw. It was balanced like socioeconomically, and then it was half Black and half white respondents. And then there were all these nice biomarkers and survey indicators and everything. I don't know if you were going to ask questions about the measures. I don't want to.
No, but that's, I mean, well, I wouldn't understand the answers if you go into all, I saw, there's different kinds of blood pressure. I guess the major point though, is that you have this, you can measure these physiological responses.
Right, at a population level. So, I mean, it can be expensive. And I think, this study was back in 2011, and it's probably those biomarker collections have gotten even cheaper in the past decade. Back then, I mean, this was a study of 1,200 people. It cost, I think, $3 or $4 million. It's just in that one city, right? So you can imagine if you want to scale up across the country. So I'm working with the Ad Health team at the Carolina Population Center. Mm-hmm. We're doing a nationwide biosocial survey. Cost $40 million, roughly. So there's those cost things you have to consider too. So in a sense, I was limited in this study to Nashville, but like you said, given the history of Nashville and the unique measures, and I could still make a case. It was a valid like case study of these processes, and these measures are hard to come by.
So when you did, after you've taking the data, analyzing, what did you find? What stands out?
So I looked. So my main analysis looked just at the black subsample. And basically what I found was, kind of what you'd expect. So, right, if you look just within the black population, the respondents who lived in, what we would call, concentrated black disadvantage, areas of concentrated black disadvantage, like these historically segregated black neighborhoods, yeah, their stress levels were higher, which makes sense because, we know those areas, and, these areas are referred to as voluntarily segregated. I mean, there are historical reasons why these areas are like this. They've been targeted by institutions, but that's a whole different conversation. But, right, we know that, so I found that, respondents in the segregated black neighborhoods, their stress levels were higher. So that's one path. We looked at, concentrated black disadvantage to stress higher. But there are these other countervailing paths I looked at when you consider the respondents in the more affluent white neighborhoods, they might not have been, they maybe weren't being exposed to the same stressors as their black peers in the disadvantaged neighborhoods, but they were reporting more interpersonal discrimination. So as the affluence of the neighborhood went up, so did the percent of neighbors who were white. And then from there, so did reports of interpersonal discrimination. And then the reports of interpersonal discrimination were linked to, a bunch of different stress processes linked to goal-striving stress, like the sense of vigilance. And that was linked to like stress hormones and blood pressure and bodily pain. So actually, when you add all this up, this is the ultimate, like the takeaway from the story. Actually, when you add all this up, there weren't really big differences among black respondents, like across the neighborhood context. That, in other words, in either context, the black respondents appeared to be exposed to stressors that were undermining their health. It's just when the black respondents who moved in these affluent, whiter neighborhoods, they were just exposed to a new set of stressors. And that's namely interpersonal discrimination and vigilance.
So it sounds like most of well, I guess the way to ask this is, are blacks in white neighborhoods, it sounds like they're not equal to their health doesn't equalize with the health of their white neighbors.
Yeah, that would probably be
they still have a disadvantage, health disparity.
Right. I mean, so I guess my study couldn't.
Is that correct?
I guess my study probably couldn't directly, well, I did look at the white respondents as well. And so what's interesting about that, as for the white respondents, when they were living in more affluent white neighborhoods, they actually reported less discrimination. And their stress levels just generally were lower than the black respondents, like regardless of neighborhood context. So I think that's a safe inference. Now, I mean, I don't have any direct measures of like, maybe there are these other outside stressors that white people in affluent white neighborhoods are facing. I don't know off the top of my head what those might be, but in this context, I think that inference makes sense.
Yeah, how I was getting there was I was thinking, well, if African Americans who are in affluent white neighborhoods have this new set of stressors that lead to their health not being somewhat different. So this is the question: is it somewhat different than the health of African Americans in segregated African American neighborhoods, or is it not different at all?
I mean, there might have been, so in my study, so I really was pointing to like a suppression effect, being that, so it is sort of like the logic of like diminished returns, I think, is the language that's used in this literature, is like the black respondents who are moving in these more affluent neighborhoods, their health didn't improve as much as we would say that it should have. So I guess I think that's kind of what you're getting at. So like, if their health would have improved a lot more if we could have like ruled out exposures to discrimination. So holding that discrimination constant, their health would have been a lot better. I think that's kind of what my model shows, like through these little countervailing pathways. That's sort of a counterfactual way to think about it. If we could have held that discrimination constant or just set it to 0, their health would have been much better. And I think that's kind of the takeaway I wanted people to get. And from that, I think really the source of the health problems I'm saying is coming from, well, who are the people discriminating against them? Well, it's the white neighbors, presumably. Obviously, I don't have a direct measure of that, but I have it aggregated at the block group level. We're basically taking these sort of testimonies from the Black respondents in Nashville, and I'm taking administrative data from their block groups, and I'm showing as they're living in block groups with more affluent white neighbors, they're also reporting higher reports of discrimination. They didn't necessarily know what the census data numbers were for their neighborhood, so it'd be an awful weird coincidence that they're just making this up. So yeah, so I think that's kind of what I was trying to get at.
So what's the, in one way, it's first off, it sounds like it's not economics. That you're providing evidence that it goes beyond that. I mean, economics is certainly not irrelevant, but because as from what you said earlier, that we have a society where you need money to buy health, but
right,
having money only isn't enough in certain situations. But right. And with a group that's got other oppressive experiences. So I guess the question is then, so that's illuminating. This is asking you to go beyond your analysis, which is, you may not, feel comfortable doing that. Right. But if you do, is there any message here for health officials or policymakers or the wider public? What should they make of this? Is there anything you'd suggest they consider doing? You've done the work, you've earned the right to give some commentary on that, should you choose to.
Yeah, this is something I've been grappling with, like, what's the intervention here? So I've actually been reading your work, Theorizing Discrimination, Age of Contested Prejudice. So I honestly wish I had gotten to that book sooner. I got to it after I wrote this paper, but I'm incorporating my dissertation. But yeah, basically, I think this idea that just merely, well, I wouldn't call it merely, but improving the socioeconomic standing of Black Americans, which is that in and of itself is a big task, but that may not necessarily be enough to close Black-white disparities. Because I think really what my study is trying to show is that this status attainment process, like, basically brings Black Americans into different spaces that have historically been white and very exclusive and guarded. And so I guess what my argument was in the last paragraph of that paper is that there's a white racism component here. Not to demonize, white people, obviously. But it's just a reality that, and in a way, I guess so. I guess the main point of my study was just to show that at least here's one case in which improving the socioeconomic standing of this particular population of Black Americans, that may not necessarily lead to better health. That there's more to health than education, occupation, and neighborhood. It's also about human relations, and that's I think that's what I've been getting out of your book in Theorizing Discrimination. So in an age of contested prejudice, so it's also about the relations, and because so when Black Americans achieve higher status, that usually will mean that they're entering predominantly white, historically white spaces that have been highly guarded. And that could lead to difficult, stressful relations from white people. And I specifically say in my paper that, this is a white person problem in many ways. We need to address how Black people are being treated in these higher status spaces, and that where, you know, the Black Americans are being sort of subjected to what I would refer to as like a gratuitous stress burden. So basically, you don't just these interpersonal strains that just don't need to be there. So yeah.
Well, as you indicated, we don't want to demonize any group, but it sounds like the problems are, as you said, it's an interactional process, and that's going to have
interactional.
So, wow, this is a powerful analysis, and you know, it really breaks down silos. You know, there's the people doing medicine, the people doing stratification, the people doing race, but we live as individuals, as whole beings, and all of these things are implicated. And I really think your paper, your discussion here today does a lot to show that how these things kind of are threaded together. So I appreciate and want to thank you for doing this, I'm sure difficult, but very illuminating work. And I want to thank you for coming here and sharing it with us today. I appreciate it.
Yeah, no, I appreciate you asking me to do it. Yeah, it was an honor to be here.
Our final segment concerns the repeal of the mask mandate for transportation. The news broke on Monday, April 18th. A federal court judge had just overturned the mask mandate. Within hours, United, American, Delta, Alaska, Southwest, and other airlines had announced that flight attendants would no longer enforce the wearing of COVID protective masks on airplanes. On some flights, passengers were informed mid-flight that flight attendants would no longer enforce the mask mandate, and YouTube and TikTok videos circulated of onboard passengers ripping off their masks and cheering. Off the planes, United Airlines delivered the following message to all employees, quote, "Effective immediately, masks are no longer required on board domestic flights, select international flights, dependent upon the arrival country's mask requirements, or at U.S. airports. This change comes after a decision by a federal judge voiding the federal mask mandate. We will continue to closely monitor the situation in the event of changes. While this means that you are no longer required to wear a mask and no longer have to enforce a mask requirement for most of the flying public, we ask that you respect the decision of those employees or customers who choose to do so, as the CDC continues to recommend wearing a mask on public transit. At the moment, there will be no changes to testing requirements for entry into the U.S." Unquote. The first thing to say is, captains that took to their radios mid-air and announced that the mask mandate would no longer be enforced put every immunocompromised person on board that flight at risk, and every immunocompromised relation of someone on that flight at risk. Generally, authorities are not allowed to change social contracts mid-transaction, just as a business, such as an airline, cannot legally change a contract unilaterally and in the middle of the transaction. Sociologically speaking, whatever one thinks of the mask mandate, the captains that ended enforcement of the mandate in the middle of the flight violated the basic expectation that the rules won't change in mid-air. Setting that issue aside, one might applaud United and other airlines that announced that passengers and employees could wear masks if they wanted. And certainly, that can help. But children are often too small to wear a mask and too young to be vaccinated. What of them? The press releases haven't said anything about that. And we know that with COVID, as with most things, multiple lines of defense are better. That's why we have seatbelts and airbags and crumple zones and DUI laws. Multiple lines of defense reduce risk on the roads between cars, and multiple lines of defense reduce risk in the air between passengers. If one person wearing a mask reduces the amount of viral matter in the air, surely 100 people wearing 100 masks reduces the amount of viral matter in the air even more. In the 100 mask scenario, each mask has less work to do because more masks are reducing the viral load. Thus, allowing people to voluntarily wear a mask neither restores the level of safety that had existed prior to the end of the mask mandate, nor addresses the issue for many passengers. Now, that's masks, but what does this episode say about contemporary US culture and politics? First thing it says is that science is not decisive in decision making. Nothing in the underlying science changed. There was no new study, no accumulation of studies, no new report that meant that the mandate should be ended, and the court decision did not attend to the science in any deep way. So that's one thing that this episode indicates. It indicates that policy is made by some mixture of science and something else. Now, that may be a preference of the society, but it is also a fact of the decision making. Another thing that we learn from this episode is that popular preferences are not determinative. A Harris poll asked a representative sample of over 2,000 Americans in mid-March to early April. Quote, "As you may know, federal regulation that requires passengers to wear masks while on planes and in airports, as well as public transportation, is set to expire on April 18th. Do you support or oppose extending this mandate?" When they obtained the survey results, it turned out that 60% of the people supported the continuation, the extension of the mandate, and 40% opposed it. Support was broad. Actually, 56% of males and 62% of females supported extending the mandate. 52% of people ages 18 to 24, 64% of people ages 25 to 40, 57% of people ages 41 to 56, and 60% of people over the age of 57 supported extending the mask mandate. When it came to income, 56% of the people making under $50,000 a year, 59% of the people making between $50,000 and $99,000 a year, and 62% of the people making over $99,000 a year supported the extension of the mask mandate. Even 62% of the people who are vaccinated and 57% of the people who are not vaccinated supported extension of the mask mandate. The only group where the percentage supporting the extension of the mask mandate was below 50% was Republicans. While 55% of independents and 70% of Democrats supported extension of the mask mandate, only 49% of Republicans did. So just a hair under 50%. So even amongst Republicans, it did make it above the 50% threshold of opposition, but it wasn't a massive opposition. Now, you would know this from the news coverage, from most news coverage. And, it might be hard to discern the popular view. I mean, the news coverage shows people cheering, the passengers cheering in public on the planes, taking off their masks. They don't show the non-passengers who are in private at home or in their office who are booing. In addition, this is one of many such issues where the public preference is clear, but the policy is stuck in the opposite direction. For example, something as polarizing as guns, or said to be as polarizing as guns. 90% of Democrats and 85% of Republicans want to prevent the people who are diagnosed with a mental illness from buying guns. 92% of Democrats and 70% of Republicans support background checks, whether the gun is sold at a gun show or sold at a gun dealer. These are broad majorities in one direction, but policy is stalled or going in the opposite direction. Now, there's several social science explanations that have been offered for this situation where you have broad majorities in favor of a policy, but the policy is actually the opposite way. One set of explanations would focus on the role of lobbyists. The argument being that lobbyists are there day after day after day, dealing with an issue of intense importance to their clients. Whereas a lot of issues, people may be very interested in them working out one way, but that is not what drives the decision they make about which way to vote. So lobbyists would have outsized influence. Another explanation is offered by a focus on the decline of institutional parties. In the past, if you have institutional parties, it means that the party bosses can bring people into line and get something done. And they can make deals across party lines. But when you have a frayed institutional structure where it's completely decentralized and each congressperson and each member of the Senate is in it in it on their own, the ability to make deals across party lines can fray. And of course, another explanation people offer is that the United States system of government offers multiple opportunities for a veto, multiple points at which popular policies can be undermined, the efforts to pass them can be resisted. It's unclear which, if any, of these explanations or if alternative explanations would be more effective. But what is clear is that the mask mandate had broad support. But it is no more, at least for now. So we can ask, what does it say about the United States, where people's will, science, well-being, and full inclusion line up on one side of a policy issue, but that side loses? We can certainly say that if you look back in time, many historians, when they analyze the United States, say it was not a democracy until the 1965 Voting Rights Act was passed. Seen in that way, we can ask, what will future historians who learn of such decisions as the mask mandate repeal say about now? That's This Week in Sociological Perspective. We'll be back next week with another interview with an author of some important sociological research and more sociological insights on an issue in the news. Till then, take care.